All right. I'm very thankful that this laptop is working right now. This isn't my Mac. I fell on my Mac whenever I fell off my motorcycle. So I'm just happy that whatever update happened, this has not fallen off. So great. Anyway, heart failure, management goals. We're going to decrease respiratory distress and work of breathing. We want to maintain adequate oxygenation and perfusion. Direct supportive efforts towards decreasing the workload of the heart. And we're going to offer patient reassurance if they're even still conscious. Place him or her in a position of comfort. Place him or her in a sitting position with the feet dangling. This is going to encourage venous pooling. That was a test question for the NR paramedic, national paramedic, which reduces venous return to the heart. You're going to slow that venous return down. Decrease the work of breathing. So that's also a side effect that comes from this. It's going to be less work of breathing. Apply pulse oximeter. That way we can see how well the body is perfusing all the way to the capillaries. Provide supplemental oxygen if needed if the pulse ox is coming back too low and if it is at a SpO2 of 94% or lower. Use non-invasive positive pressure ventilation to manage pulmonary edema associated with heart failure so that the patient receives the following benefits. Improves oxygenation and perfusion by reducing the work of breathing. Maintain alveolar inflation. I want to make sure that y'all can see the slide. All right, cool. Alveolar inflation, so the little sacs in the lung, it's going to inflate those. Improves pulmonary compliance, slows the respiratory rate, thereby decreasing the work of breathing, heart rate, and SBP. So you have like a quadruple silver bullet's my favorite word of the month lately. So that's basically what that does at that point. One thing makes another thing go positive, makes two things go positive, makes another thing go positive. So solving one problem puts other stuff back in check. That's the body's natural compensatory mechanism. Once you fix one thing, the rest can compensate with it. Facilitates delivery of bronchodilators. Reduces, so bronchodilator is going to open up the bronchioles, the bronchioles, and is it bronchi? Bronchi of the lung, the main stem. I forgot what that's called. Reduces preload and afterload, improving cardiac output. Yes, preload and afterload, improving cardiac output. Decreases the work of breathing. Do not use non-invasive positive pressure ventilation if the patient has, off the top of my head, trauma. What else? We'll see. Compromised airway. What is compromised? Oh yeah, so if they're choking. FBAO, you don't want to force something more down into the bronchiole. Altered mental status. We don't know what is causing that, so we don't want to expedite whatever that is. Risk of aspiration, again, you're forcing things where they shouldn't be. And pneumothorax. We do not want to essentially stretch and pop a balloon, right? We don't want to stretch and pop the lungs. SBP of less than 90 millimeters Hg. Again, off the top of my head, I think this is for the sake of stimulating, I don't even want to say it, but I'm just thinking stimulate the vagus nerve to drop it even more, but I don't think that's what that is. May be necessary to use advanced airway. Monitor the patient's respiratory status using waveform capnography. We're going to limit patient's physical activity because we don't want to break the heart. Don't move it, it's fragile. Place the patient on a cardiac monitor and then obtain a 12-lead EKG. Establish IV access. Pharmacologic therapy for the heart failure may vary slightly by EMS system. So we're going to check our local protocol. Sublingual NTG may be given to reduce both preload and afterload, thereby supporting cardiac output. NTG. What is aspirin? That's what we give sublingual, or we also give nitroglycerin. Nitro tablet glycerin, NTG. I don't know what NTG is, but we put 0.4 milligrams of nitro sublingually in order to reduce preload and afterload. Furosemide is not currently recommended for the use of treating heart failure and acute pulmonary edema. Surgically implanted ventricular assistance device, so these are also called VADs, VADS, may be used in patients who have heart failure. It acts as an artificial ventricle. Is this recording? Yeah. Does not depend on the contractility or electrical conduction of the patient's heart. So if something's janky with the electrical, we don't have to worry about that because this is taking the place of it. Can be placed in the left ventricle, LVAD, the right ventricle, RVAD, or both biventricular assisted devices, BiVAD. LVF is more common than RVF. So the LVAD is the most common type of VAD. A VAD is used in the following situations: to allow the heart to rest until the patient's heart can resume pumping function, as a bridge to heart transplantation, as lifetime therapy, also called destination therapy. There are several types of VADs, and they typically consist of a blood pump, tubing, an inflow of cannula and outflow cannula, and an external power source that connects to a controller. D, alarms. My knee is killing. Why does it only kill me whenever I'm standing here? VADs are characterized according to the blood flow, such as continuous pulsatile. The length and time that the device can be used for circulatory support, short, intermediate, and long-term. The source of the driving power could be pneumatic, could also be electric. The device location could be internal or it could be external. What do they call that? A life vest? Vest for life? I think it's a life vest. Transcutaneous VADs. Both pump and the power source are located externally. Implantable VADs. The pump is located inside the body and the power source is located externally. LVADs, the blood is withdrawn from the left atrium, the apex of the left ventricle, through a tube into the LVAD, and then returned to the ascending aorta via a second tube. RVADs, the blood is withdrawn from the right atrium into the RVAD and returned to the pulmonary artery. Device malfunction or failure could have a thromboembolism, could have bleeding, could have RVF, right ventricular failure, could have infection, sepsis. A VAD coordinator can assist you in making the treatment and transport destination decisions. If you have an expert on your equipment, whether that's a parent or whoever's in the home that knows, that's a person, that's an asset. Contact the VAD coordinator if the patient with a VAD experiences a cardiac arrest. If the patient requires defibrillation or cardioversion, be careful not to place the pads directly over the pump. You do not want to shock it. I mean, it's not gonna, never mind. Yeah, don't shock it. Cardiac tamponade. Pathophysiology. This occurs when buildup of the pericardial fluid compresses the heart, impairing contraction and restricting ventricular filling. May develop gradually if caused by an infection or tumor. Could be rapidly if it's from heart surgery or pacemaker, central venous catheter insertion, central line, or cardiac trauma such as a stab wound or a gunshot. Cardiac tamponade. Patient is usually too ill to give his or her medical history. Could have anxiety, restlessness, could also be short of breath, could have tight chest, dizziness. Suspect that cardiac tamponade in any patient is penetrating wound to the chest or upper abdomen. True. If it is not from trauma, the patient may have a history of medical illness such as pericarditis and end-stage renal disease. Breathing sounds will be equal. Differentiate between tamponade and tension pneumothorax. In cardiac tamponade, the lungs are not affected. So you're gonna not have issues when you're listening to lung sounds. And trachea will be at the midline. So if it was if it was a tension pneumothorax, then like your trachea is being pushed one direction or the other. Cardiac tamponade produces a classic trio sign known as Beck's triad. So we're gonna have JVD. If I did a handstand, you could see these inflate. because these are your jugular veins. There's a lot of blood that travels through those. You're also going to have hypotension, so there's going to be lower blood pressure because it's being forced in here. It is causing backup. It's like traffic. Muffled heart sounds. So we're going to have muffled heart sounds. Again, you have all that blood that's preventing it from really moving, so it's kind of constantly flooded with blood in the heart. So it always sounds like if you were to put your ear to a water balloon, I guess, as opposed to something that's sometimes full and sometimes that's not. Other signs of cardiac tamponade: cold, pale, mottled, cyanotic skin, tachycardia. So the body's compensating, it's going to speed up, try to push that blood. Cold, pale, mottled, cyanotic skin. Obviously, you're not perfusing, so it's not going to be bright red like oxygenated blood is in the capillaries and blood vessels. Weak, absent peripheral pulses. Yeah, it's not getting there. You might not even feel them. Narrowing pulse pressure. This is an early sign. Pulsus paradoxus. I have that anyway. May be absent if the patient has severe hypotension. Signs and symptoms mimicking heart failure. EKG is of limited value, may show electrical alternons, but we're treating the patient, we're not treating the screen. Screen helps us though. Management. If trauma is the source of the patient's signs and symptoms, we're going to address any life-threatening hemorrhage. Ensure that adequate oxygenation and ventilation. We're going to apply a pulse oximeter and provide supplemental oxygen as needed to maintain the patient's SpO2 at 94% or higher. We're going to apply a cardiac monitor, avoid performing additional procedures that might delay transport. Establish IV access en route to definitive care, the hospital. Pericardiocentesis, the ultimate treatment to withdraw fluid. So the needle is inserted, oh, this is fun. Needle is inserted into the pericardial space to aspirate excess fluid. Let's see, it's almost like, not actually I think it is mid-axillary. Yeah, you're gonna stab it right up there, third intercostal space. Let's see what it says. Needle is inserted into the pericardial space to aspirate fluid. So just like the lungs, lungs are in a sac. The heart is in a sac. This is that interstitial pericardial space. Now when it fills up with blood, it keeps the heart from beating because it's pushing against it. So we have to eliminate that blood. How do we do that? We stick a shunt, a needle. It's going to aspirate all of that blood out so the heart can beat better again. Withdraw as little as 50 milliliters may give a significant improvement. If you have a syringe, that's 20. 2 syringes is 40. So 2 syringes and a half, that's 50. That's going to drastically improve. Transport to a facility that can do this procedure. So what is it? What do we do? What is it called when we do it? Cardiogenic shock. Pathophysiology may occur as a complication of shock in any cause. May also occur if myocardial contractility has diminished because of prolonged cardiac surgery, ventricular aneurysm, cardiac arrest, or ventricular wall rupture. Transient cardiogenic shock can occur after resuscitation. If the family members are present, ask whether or not the patient has a history of heart disease. Am I running out? No. History could often include cardiomyopathy, congenital heart disease, recent myocardial infarction, especially in patients who are older, have had a STEMI before, have a history of previous myocardial infarction or heart failure, have an anterior infarction at the time of shock develops, compensated cardiogenic shock. Patient may experience the following symptoms. So they could have restlessness, agitation, confusion, JVD, crackles in breath sounds, weak and rapid peripheral pulse, pale, mottled skin. Cool, moist extremities, narrow pulse pressures, EKGs may show evidence of old and new infarction. Could have right side chest leads that detect right ventricular what is interference. If associated with cardiac tamponade, muffled heart sounds may be heard, decompensated with cardiogenic shock. Symptoms: we have altered mental status or unresponsive rapid and shallow breaths, pulmonary congestion and crackles, and we also have absent peripheral pulses. weak and rapid central pulses, pale, mottled, and cyanotic skin, cold, sweaty extremities as ventricular function worsens, cardiac output fails, the systolic blood pressure progressively decreases. Management of this, we're going to focus on strengthening the contractility without increasing the heart rate, altering preload and afterload, controlling any dysrhythmias that are contributing to shock. We're going to apply pulse ox and administer supplemental oxygen as indicated. Place the patient in a sitting position with feet dangling for venous pooling. Ensure that the patient's physical activity while in your care. We're going to place the patient on a cardiac monitor to establish IV access. We're going to obtain a 12-lead EKG and maintain normal body temperature. Give IV fluids, medications per protocol, or medical direction. We're going to administer a trial of fluids to determine whether the shock has a hypovolemic component. If so, rapidly infuse 100, 200 milliliter normal saline and closely monitor if the patient's mental status, breath sounds, pulse, blood pressure, and withhold further fluid administration if the patient's condition deteriorates or crackles or hepatomegaly develop. Crackles or hepatomegaly. I wonder what that is. I haven't heard that. Something with the blood. Cardiogenic shock, again, vasoactive IV medications to treat cardiogenic shock include dopamine, norepinephrine, and epinephrine. All of these are vasopressors. If you are instructed to give vasoactive medication, check the following: the IV site often, the patient's response, give additional emergency care as instructed by the medical direction. If the patient does not improve, treat dysrhythmias that are contributing to shock and provide emotional support to the patient and their family. Except for correcting the life-threatening dysrhythmia, there are no other measures that you can take in the field to stabilize a patient in cardiogenic shock. Complete a fibrinolytic check while en route. Give more intel to the doctors. Hypertensive emergencies. Hypertension is a diastolic pressure exceeding 90 millimeters Hg, called the silent killer because it usually produces no signs or symptoms. A person can have it for years without being aware of it. Uncontrolled high blood pressure can lead to low vision, blindness, increased risk of serious health conditions such as stroke, heart attack, kidney failure, heart failure. A hypertensive emergency is defined as an acute elevation of blood pressure with evidence of end organ damage. A common cause of failure to take blood pressure medication or other treatment as prescribed. Other causes result from pregnancy, toxemia present, pregnancy, hypertensive encephalopathy, I can't even say it, is often called acute hypertensive crisis, may complicate any form of hypertension. Usually it's going to be signaled by a sudden escalation in the blood pressure to levels exceeding 200 over 130 millimeters Hg. Pathophysiology. Often causes result from advanced atherosclerosis or arterial sclerosis. I'm not sure what the difference is from those, but basically clots break off. Blood pressure is at rest of greater than 140 or 90 millimeters Hg. A single reading does not constitute hypertension. It suggests that the patient have his or her blood pressure rechecked a couple of times in the following months. Persistent elevation of diastolic pressure is an indicative of hypertensive disease, which can cause significantly shorter lifespan. Predispose the person to other medical conditions, including renal damage, stroke, heart failure. Hypertensive emergencies require rapid lowering of blood pressure to prevent and limit organ damage. Malignant hypertension often occurs when there's a rapid rise in blood pressure, causing acute and progressive damage to organs such as the heart, brain, and kidneys. Determine that the factors of hypertensive encephalopathy is usually the mean arterial pressure, the MAP. Remember this, what is this equation? It's like 1/3 times the sum of both of them over systolic minus I did this video a while ago. It's buried somewhere in my YouTube. When the MAP exceeds 150 millimeters Hg, fluid leaks through the blood-brain barrier, causing increased intracranial pressure, ICP. The first noticeable symptoms include nausea, severe headache, vomiting. Those symptoms are followed by seizure, mental status alterations, focal neurological signs, sudden blindness, aphasia, hemiparesis. Focal neurological disease, interesting. If untreated, death may occur within a few hours. And this is hypertensive emergencies. Assessment. Hypertensive emergencies can develop rapidly. Symptoms include headache, blurred vision, dizziness, ringing in the ears, tinnitus, dyspnea, nosebleed, muscle cramps, weakness, palpitations, P&D and orthopnea, missed one, chest pain or tightness. Ask the patient about what medication he or she takes. Prescribed over-the-counter medications, recreational drug use for fun, sick appearance, mental status may range from responsive to altered unresponsive. Pale, flushed skin, or normal skin that feels dry, moist, warm, or cool to the touch. Strong bounding peripheral pulses, high DBP, usually higher than 130. Seizures, signs of heart failure. Signs inconsistent with acute myocardial infarction and ischemic changes that may be seen on a 12 lead. How many more of these? Let's do it. Provide supportive care. We're going to administer oxygen, establish an IV line, apply cardiac monitor and pulse oximeter, maintain SpO2 at 94% or higher, and we're not going to delay transport. Provide care according to the local protocol for patients with heart failure or chest discomfort, often reassuring the patient's family. If a long transport time is unavoidable, paramedics may need to initiate drug therapy in the field. Labetalol, normodinitranidate. So these are all the same. Labetalol is normodinitranidate. So these are alpha and beta blocking properties which decrease the overall peripheral vascular resistance and prevent reflex tachycardia. Contraindicated in the patients with asthma and COPD. Keep the patient supine. Measure the blood pressure at least every 2 to 3 minutes. We're going to stop the infusion when the blood pressure has fallen to the target level. My understanding is we don't want to, if we're using pharmacological means to lower the blood pressure, you don't want to lower it more than 10% without doing something else to the body that naturally would make it compensate and lower. That's the case with labetalol, from my understanding. So alpha and beta blocking properties decrease peripheral's out here, this is non-peripheral, vascular resistance, so that is going to almost cause this to dilate and prevent reflex tachycardia. So yeah, if you open this up, like pretend that my arm is a balloon, I open up the amount of blood that can go into here, it's going to drop my blood pressure here. Now you do it here, even more so. You do it through my legs too, peripheral, you drop my blood pressure. Alpha and beta properties. Cool.